my name is Megan Byrne and this is my presentation on fetal development, monitoring and intervention. So how a healthy embryo and fetus develops. Human development begins at fertilisation when a sperm cell fuses with an ovum in the fallopian tube to form a zygote. The zygote undergoes rapid mitotic division as it travels towards the uterus, forming a morula and then a blastocyst by day 5 to 6. The blastocyst consists of an inner cell mass, which becomes an embryo, and an outer trophoblast, which forms part of the placenta. Around day 6 to 10, implantation occurs in the endometrium. The trophoblast differentiates and contributes to the formation of the placenta, which enables nutrient intake, gas exchange, waste removal, and hormone production, including HCG to maintain pregnancy. At week 3, gastrulation forms the 3 primary germ layers. Ectoderm, which contributes to the nervous system and skin, mesoderm, which is muscles, bones and cardiovascular system, and endoderm, which is respiratory and digestive systems. The neural tube begins forming, which creates the future brain and spinal cord, and the primitive heart tube develops. At week 4, the embryo is C-shaped with a distinct head and tail region. The heart begins beating at approximately day 22 to 23, and early blood circulation is established. Limb buds appear. At week 5 to 6, rapid brain growth gives the embryo a prominent forehead. Eye and ear structures begin forming. Limb buds elongate, hand and foot plates develop, and the heart is partitioning into chambers. At weeks 7 to 8, digits separate, the major internal organs establish in primitive form, and facial features become more recognisable. By the end of week 8, the embryo is approximately 2 to 3 centimetres long. All major organ systems are present but immature, and at this stage it is termed a fetus. The fetal period, which is considered weeks 9 to birth. So the first trimester, which is weeks 9 to 12, there is rapid growth in length, external genitalia differentiate, eyelids fuse temporarily, the liver produces red blood cells before the bone marrow takes over. Spontaneous movements begin, though not yet perceivable by the mother. Reflexes such as sucking in may begin, and the fetus has a disproportionately large head relative to body size. In the second trimester, which is weeks 13 to 27, the body proportions become more balanced, fine hair covers the skin, vernix caseosa, which is a protective waxy coating, develops, eyebrows and eyelashes appear, the skeleton ossifies further, bone marrow becomes the primary site of hematopoiesis, and the cardiovascular system is well established. The lungs develop branching bronchi and primitive alveolar structures, and around 18 to 20 weeks the mothers may feel movement. The auditory system develops and the fetus can respond to sound at around 24 weeks. Taste buds function and the fetus can swallow amniotic fluid, and the retina develops a sensitivity to light. By 24 weeks, limited survival outside the uterus may be possible with intensive neonatal care, although lung immaturity remains a major factor. In the third trimester, which is considered weeks 28 to 40, rapid weight gain occurs due to subcutaneous fat accumulation, skin becomes less wrinkled, the hair on the skin gradually decreases, significant brain growth and cortical folding occur, improved coordination of reflexes such as grasping or sucking, sleep-wake cycles become more established, type 2 alveolar cells produce increasing amounts of surfactant, reducing alveolar collapse and enabling effective breathing after birth. Practice breathing movements occur in utero. The fetus can hear clearly and may recognise a maternal voice. Visual responses to bright light are present, and pain perception pathways are developed through cortical interpretation remains debated. By 37 to 40 weeks, the fetus is considered full term. The average length is approximately 50 centimetres and the weight is around 3 to 3.5 kg. The lungs are mature, the liver can regulate glucose more effectively, and coordinating sucking and swallowing allow feeding after birth. In the final weeks, the fetus typically adopts a head-down position. Maternal fetal hormone signalling contributes to the initiation of labour. Surfactant levels are sufficient for independent respiration, and organ systems are mature enough to support the extrauterine life. At birth, the transition from placental to pulmonary respiration occurs. The foramen ovale and ductus arteriosus begin to close, and the newborn adapts to independent circulation. Fetal monitoring. Fetal monitoring during pregnancy aims to assess growth, structural development, placental function, and overall well-being. The primary imaging modality used is ultrasound, including specialised forms such as the Doppler ultrasound. These techniques are non-invasive, safe, and provide real-time assessment. Ultrasound, which is a 2D system, uses high-frequency sound waves to create real-time images of the fetus and intrauterine environment. In the first trimester, you may have a dating and viability scan. This confirms an intrauterine pregnancy, detects fetal heartbeat, determines gestational age using crown to rump length, identifies multiple pregnancies, and detects early structural abnormalities. Accurate dating improves prediction of expect date and identification of growth abnormalities later in the pregnancy. In the second trimester, you may have an anomaly scan, which is taken around 18 to 21 weeks. It will be a structural assessment of the brain and spine, the heart with a 4-chamber view, abdominal organs, limbs. It will assess the placental location, measures amniotic fluid volume, and there's also a possibility to find out the gender of the fetus if wished. This scan screens for congenital abnormalities and structural defects. Some people may be offered growth scans in their third trimester or in a high-risk pregnancy. These estimate fetal weight using biometric measurements. Ultrasound can also assess amniotic fluid volume and fetal position, whether they're head up or head down. The Doppler ultrasound measures blood flow using the Doppler effect and is particularly valuable in assessing placental and fetal circulation. There is the umbilical artery Doppler, which evaluates placental resistance, identifies reduced, absent, or reversed end diastolic flow, detects placental insufficiency, and is essential in suspected fetal growth restriction. There's a middle cerebral artery Doppler, which assesses redistribution of blood flow and detects fetal anemia, and a uterine artery Doppler, which assesses maternal blood supply to the placenta and is used in predicting risk of preeclampsia or growth restriction. Abnormal Doppler findings may prompt increased surveillance or early delivery. Fundal height measurement is a simple, non-invasive clinical method used from approximately 24 weeks gestation onwards. The procedure is the measurement from the symphysis pubis to the top of the uterine fundus, recorded in centimetres, and is plotted on a customised growth chart. In a normal growing pregnancy, fundal height in centimetres roughly corresponds to gestational age in weeks plus 2 centimetres. The clinical useness of fundal height charts is that it monitors fetal growth trajectory over time, detects small for gestational age or large for gestational age patterns, identifies deviation from expected growth centiles, and triggers referral for ultrasound assessment if abnormal. Customised charts improve accuracy compared to population-based charts. Ultrasound imaging provides structural, developmental, and growth information throughout pregnancy, while Doppler ultrasound specifically assesses placental and fetal circulation, identifying compromised blood flow. Fundal height measurement offers a cost-effective, accessible screening tool for monitoring growth trends. Together, these methods enable early detection of abnormalities and guide timely intervention to optimize maternal and fetal outcomes. Okay. So fetal monitoring during labour assesses fetal well-being primarily by evaluating the fetal heart rate, also known as FHR, and its response to uterine contractions. The aim is to detect hypoxia or acidosis early to reduce risk of adverse neonatal outcomes. So, monitoring in the different stages of labour. In the first stage, in low-risk pregnancies, intermittent auscultation is recommended. The fetal heart rate is listened to after a contraction for at least 1 minute. A normal baseline is 110 to 160 beats per minute. This method supports mobility and physiological birth. In higher risk labours, continuous electronic fetal monitoring, or CTG, is used. CTG assesses a baseline rate, a variability, which is 5 to 25 beats per minute reassuring, accelerations and decelerations, which may indicate cord compression or hypoxia. Persistent late decelerations or reduced variability may suggest fetal compromise. In the second stage of labour, monitoring continues as contractions intensify. With IA, fetal heart rate is checked after each contraction or at least every 5 minutes, and with CTG, continuous assessment is maintained due to increased hypoxia risk and during pushing. If CTG is normal, further assessments such as fetal scalp stimulation or blood sampling may be used to assess acidosis. When additional monitoring is advised. So continuous monitoring is recommended when risk factors are present, such as maternal pyrexia, hypertension or diabetes, meconium stained liquor, induction or oxytocin use, epidural use, previous caesarean section or prolonged or complicated labour. These all increase the risk of fetal compromise. So how monitoring influences intervention. If abnormalities are detected, initial management may include maternal repositioning, IV fluids, stopping oxytocin or treating the hypertension. If pathological patterns persist or acidosis is confirmed, birth may need to be expedited by instrumental delivery, which is forceps or vacuum, or an emergency caesarean section, which is more commonly known as a C-section. This may alter the original birth plan to prioritise the fetal safety. Fetal monitoring therefore guides intrapartum decision making by balancing physiological birth with timely intervention when compromise is suspected. Screening process for chromosomal abnormalities. So antenatal screening aims to identify pregnancies at increased risk of chromosomal abnormalities, enabling informed decision making and appropriate management. So there's trisomy screening, which there's trisomy 13, 18 and 21. In the UK, all pregnant women are offered screening for them. Trisomy 21 is Down syndrome, trisomy 18 is Edwards syndrome, and trisomy 13 is Patau syndrome. So in the first trimester, you'll be given a combined test, which is 11 to 14 weeks. This includes ultrasound measurement of the nuchal translucine, which is also referred to as NT, maternal surname markers, which is the HCG and the PAP-A, and maternal age risk calculation. This result provides a risk estimate, e.g. 1 in 100. A higher risk result leads to an offer of further testing. So there's non-invasive paternal testing, which is also known as NIPT. It analyses cell-free fetal DNA in maternal blood. It has high sensitivity and specificity for trisomies 21, 18 and 13, but remains a screening, not a diagnostic test. A diagnostic test is if screening indicates a high risk. So the diagnostic options include the chronic villus sampling, which is CVS, at around 11 to 14 weeks, and amniocentesis from 15 weeks. These provide definitive karyotyping but carry a small miscarriage risk. So, genetic screening for hereditary diseases. Genetic screening identifies carriers or affected fetuses for inherited conditions. In the UK, screening is offered based on family history or ethnic risk factors. For example, sickle cell. Sickle cell disease is an autosomal recessive hemoglobinopathy. All pregnant women in England are offered screening at booking. Screening is particularly important in individuals of African, Caribbean, Middle Eastern, Mediterranean, or South Asian ancestry. A maternal blood test identifies carrier status. If the mother is a carrier, the father is then also offered testing. If both parents are carriers, diagnostic testing, which is the CVS or the amniocentesis, may be offered. This allows informed reproductive choices and early neonatal planning. Screening for fetal health conditions. So health conditions such as fetal anemia may result from red cell alloimmunization, which is also like Reese's incompatibility, or infection. The screening methods include maternal blood group and antibody screening at booking at 28 weeks, Doppler ultrasound assessment of middle cerebral artery peak systolic velocity, which is MCA-PSV. Increased velocity suggests anemia. The treatment options, if moderate or severe fetal anemia is detected, is an intrauterine blood transfusion via the umbilical vein may be performed, or early delivery may be considered if gestation is advanced. And also there's anti-D immunoglobulin to give to rhesus negative mothers to prevent sensitization. Screening in pregnancies identifies risk for chromosomal abnormalities, inherited diseases, and fetal health conditions. While screening tests estimate risk, diagnostic tests confirm diagnosis. Early detection enables counselling, targeted monitoring treatments, or informed decisions regarding continuation of pregnancy, supporting optimal maternal and neonatal outcomes. This slide is about miscarriage, risk factors, misconceptions, and management. Miscarriage is defined as the spontaneous loss of a pregnancy before 24 weeks gestation. It is common, occurring in approximately 1 in 4 recognised pregnancies, and is most often due to factors completely outside of parental control. Risks for miscarriage include chromosomal abnormalities. This is the most common cause of early miscarriage, and it is sporadic chromosomal abnormalities, particularly things such as trisomies. These genetic errors usually occur at fertilization and are not caused by parental actions. Maternal factors that may increase the risk of miscarriage is advanced maternal age. Risk increases significantly if you're over 35 years old. If you've had previous miscarriages, if you have uncontrolled diabetes or thyroid disease, if you have polycystic ovary syndrome, also known as PCOS, uterine abnormalities such as fibroids distorting the cavity, antiphospholipid syndrome, smoking, excessive alcohol consumption or illicit drug use, and obesity, or on the other end, severely underweight. There are also infection and environmental factors that may cause a miscarriage, such as severe systemic infection, exposure to elevated levels of toxic substances or radiation, or significant trauma. However, these are less common causes compared to chromosomal abnormalities. Reducing risk where possible. While many miscarriages are preventable, risk of one may be reduced by taking folic acid at preconception and in early pregnancy. Ceasing smoking and limiting alcohol. Optimizing weight before pregnancy, either gaining or losing. Managing chronic conditions such as diabetes or thyroid disorders. Early antenatal care. Aspirin and heparin therapy in women diagnosed with antiphospholipid syndrome. There are many misconceptions about miscarriages, and it is important to dispel myths around miscarriage. Everyday physical activity, exercise or lifting moderate weights do not cause miscarriage. Sexual intercourse in a low-risk pregnancy does not cause miscarriage. Stress alone is not a proven direct cause of miscarriage. Most miscarriages are not caused by something the pregnant person did or did not do. Management of miscarriage. Management depends on gestation, symptoms, and patient preference. So there is medical and surgical management. So expected management is allowing miscarriage to occur naturally. This is suitable if the patient is clinically stable. Medical management, so medications such as misoprostol, some combined with mifepristone, are used to stimulate uterine contractions and expel retained tissue. Surgical management is uterine evacuation, e.g. manual vacuum aspiration or surgical management of miscarriage may be required if there is heavy bleeding, signs of infection, retained products of conception, and a patient preference for speedier resolution. Miscarriage is common. Around 1 in 4 women experience miscarriage. It is most often caused by chromosomal abnormalities beyond parental control. While some risk factors can be modified, many losses are unavoidable. Management options include expectant medical or surgical approaches tailored to clinical need and patient preference. Sensitive, non-judgmental care and clear information are essential components of support. If you've been affected by anything I've just said, there are some helplines that are free to call any time of day. Termination of pregnancy, indications and procedures. Termination of pregnancy, or TOP, is a legal medical procedure here in the UK and is carried out under the Abortion Act 1967 and amended in 1990. Decisions are complex and individual, and care should always be non-judgmental, confidential and patient-centred. Situations where termination may be considered are under several circumstances. So, for example, risk to maternal health. Serious risk to a woman's physical health, for example, severe cardiac arrest or uncontrolled hypertension. Significant risk to mental health. Life-threatening pregnancy complications such as severe preeclampsia or sepsis. There may be a severe fetal abnormality. Termination may be offered following diagnosis of serious congenital or chromosomal conditions such as Down syndrome, Edwards syndrome, or Patau syndrome. It may be considered in cases of lethal structural abnormalities such as ancephaly or conditions incompatible with life. Pregnancies resulting from a sexual offence. If the pregnancy is following a rape or a sexual assault, it may significantly impact mental and physical well-being. Or socio-economic or personal circumstances. Termination may be considered if continuing the pregnancy would pose greater risk to the woman's physical or mental health than ending it. This includes complex social, financial, or safeguarding circumstances. Medical termination of a pregnancy is commonly used in early pregnancy, which is up to 10 weeks, and also a bit later in hospital settings. The process consists of 2 medications, mifepristone, an anti-progesterone medication that blocks progesterone, causing the pregnancy to detach from the uterine lining, and misoprostol, which you take 24 to 48 hours later, which stimulates uterine contraction to expel the pregnancy tissue. The process resembles a heavy miscarriage with cramping and bleeding. Later gestations may require repeated doses and closer monitoring. Or there is surgical termination of pregnancy. Surgical methods are chosen depending on the gestational age. Early pregnancy, which is usually up to 14 weeks, there may be the option of vacuum aspiration, manual or electronic suction, performed under local or general anaesthesia and takes approximately 5 to 10 minutes. Or in later pregnancy, there will be a dilation and evacuation, also referred to as a D&E. Cervical preparation is required beforehand using misoprostol or osmotic dilators. Surgical methods are generally quicker and involve less bleeding duration than medical methods, but require a clinical setting. All individuals, no matter the procedure, should be offered contraceptive counselling, screening for sexually transmitted infections if appropriate, and emotional support and signposting to counselling services. Termination of a pregnancy may be considered in cases involving maternal health risk, severe fetal abnormality, sexual violence, or significant personal circumstances. Both medical and surgical methods are safe and effective when performed to clinical guidelines. Sensitive, individualised care and informed consent are essential components of practice. And if you've been affected by anything I've just said about the termination of a pregnancy, there are also some free call lines that you can call. And that's my reference list. Thank you very much.